his PhD at the University of North Texas in Denton, Texas. Subsequently, he completed his Doctor of Osteopathic Medicine at Texas College of Osteopathic Medicine at Fort Worth, Texas. Subsequently, he underwent internship, neurology residency, and fellowship in neuromuscular medicine at the Cleveland Clinic Foundation. After that, he went on for a second fellowship in neuro-oncology at the London Regional Cancer Center in London, Ontario, Canada. He's been at the Cleveland Clinic Foundation for many years and has built up the program from the beginning, and has served as the program director for the Neuro-Oncology Fellowship. Among achievements, he's been on lists for Best Doctor in Cleveland, Ohio, as well as America various times. He's had at least 7 book chapters and over 60 publications and dozens of educational lectures. So I just wanted to welcome Dr. Stevens and thank you for being here.
Thanks, Matt. Let me see if I can share my screen properly here. So can you see it?
That looks
Yes.
great.
Okay, and you can hear me okay?
Yes, you sound great.
Excellent. So welcome. Thanks, Matt. Thanks for the introduction. I'm going to discuss Neuro-Oncology 2022, what's new in brain tumor classification. I talked to Matt previously. I'm going to make it practical. We're going to talk about management. If there are any neurosurgeons on, I always like to poke fun at my neurosurgical colleagues once in a while, so don't be offended by that. I'd like to thank Matt. Matt, as I recall, I think we did a book chapter together. Previously, Matt spent time with us, and you've got a good one there, so you're very fortunate. I'd also like to thank Corey. Of course, Corey and I have done a couple little sessions, so if I screw up, it's all on me because Corey has briefed me on this, so hopefully I won't. And I also told her that I'm happy to share my slides with her after if you guys need the slides. So if there's any interest, I'm happy to do that. This is my grandson, Jack. He lives in northern British Columbia. So you guys are actually much closer to him than I am. He's an up-and-coming hockey star. You can see my granddaughter up here, Peyton, loves climbing along. So I will go through things, and I have a lot of slides. If for some reason we get up against the clock or it's going too long, I'll just stop as we move through. So let me just, there. So disclosures. I do some medical editing. I do have R01 and U01 funding. I am a podcast host. I actually did 3 podcasts earlier. I do it for Neuroscience Institute, so I do them based on neurosurgery, psychiatry, physiatry, neurology. If you have any interest, you can go to Consult QD and you can just search under neurosciences and you can see our podcast, or if you're an Apple or Spotify user, you can go to Neuropathways and find. And I do have one last disclosure that Matt kind of mentioned, and that is that I am Canadian as it goes through there. So my daughter used to live in Vancouver, so I would fly to Seattle quite a bit, and hope to get back up there again in the near future. So I put here, I thought I'd never see it. This was my daughter. This is just outside of Prince George, where my daughter lives this past year. And of course, you can see the northern lights here, which are spectacular. But what I thought I would never see, because I wanted to give you one positive thing, and that is a chemotherapy that looks like it's showing some benefit in brain tumor. And I thought I'd just segue just for a second. This is von Hippolindao disease. And for those of you out there that have you looked after, it's a devastating genetic disorder, autosomal dominant, where patients at a very young age have multiple hemangioblastomas affecting the posterior fossa, the spine, the eyes, all those types of things. And after a while, they get tired of having surgery. And this drug was released, and this is our first use with it. Dr. Dewan is one of our current fellows. So we got him working hard because it's just August now. And Dr. Peerboom, one of our other neuro-oncologists, and I, and our experience. And you can see this pre-treatment. This patient has had multiple surgeries before, had some gamma knife, did not want to have any additional surgery. And you can see this enhancing lesion on the left side of the posterior fossa. And this is after 2 cycles, and you can see these spots here better. And I'm not showing it, but if you go to the article, you'll see some in the spinal cord with a lot of decrease in brain edema. So very exciting stuff. I talked to our fellow yesterday, and I did put the web address down. The article was just released and is available at this point in time. So something very exciting, and really looking forward to a change in these patients. So I'm going to discuss CNS imaging relative timing, relative to brain tumor surgery. We're going to discuss the role of anti-seizure drugs, steroid use in brain tumor patients. We're going to discuss briefly the new WHO grading for gliomas, the significance of IDH1 mutations, MGMT methylation, standard of care, and we'll talk a little bit about some trials. We'll also discuss some novel treatments that we're doing, laser interstitial thermal therapy and focused ultrasound. So I like to start with a case example, and I think it's always a good way to do it. So 36-year-old right-handed male came to the outpatient department for treatment options for recently diagnosed astrocytoma. In May, he had problems expressing himself. June and July, some inappropriate behavior, was involved in an MVA that in retrospect was probably having, I know we don't use this term anymore, but a complex partial seizure. I still think that way, where there's an alteration of consciousness. Right hand tingling, expressive problems. So, after 4 or 5 events as a good male, to finally decide to seek some medical care, had a CT and MRI. When they came to see me, they only had the pre-op CT scan, had a subtotal resection on the outside facility. No post-operative MRI was done, which we'll discuss. Pathology showed an anaplastic astrocytoma. I highlighted this a different color because on the new WHO grading for tumors that we'll see a little bit later, they've removed the term anaplastic. So that used to refer to our grade 3 astrocytomas, oligodendrogliomas, and mixed tumors, but we just call them grade 3 now. They've removed anaplastic. This patient had their steroids stopped 3 days post-operatively and are on phenytoin for probable seizures. It sounds like he had a seizure as it went through. This is a CT scan the patient brought with him. You can see it's a CT scan without. You can see there's a large area of vasogenic edema in the left frontal lobe, maybe even a little subfalcine herniation, certainly compression on the left frontal lobe, a little bit of shift that's going on here. So certainly something that is concerning. Looks like you can see something looks a little more solid here. So why do we need to do post-operative MRIs? This patient did not receive a post-operative MRI, and it should be done within 48 hours of surgery. Why? Because we're going to have to evaluate a treatment effect down the line. And we're going to need to have something to compare it to. And we want the most accurate scan to compare it to. And if we do it early enough, we'll have decreased artifact that's there. Otherwise, we're going to have more artifact greater than 48 hours, and it's going to be difficult to interpret. Here's another case from our brain tumor conference that we reviewed. Again, another outside case. You can see the T1 MRI with contrast here, right side, left side. And this is a gadolinium injected scan. And you can see there's probably something over here in the right posterior temporal lobe, maybe a little bit of faint enhancement. This is the post-operative MRI. And in this case, they elected to do the scan 2 weeks post-operatively. This is a T1 without. So there's probably some proteinaceous material in here, blood products over on the right side. And then when you look at the contrast enhanced MRI scan, you can see all this contrast enhancement on the edge of this patient, which you would not probably have seen if it was done within 48 hours. So why is the enhancement here? Well, in his case, the enhancement is probably there related to DWI changes. I'm not showing you the DWI image, but he had ischemic changes around the surgical cavity. So as you know, if people have an ischemic event, you can see enhancement a week or so later. So this is all enhancing stuff from the ischemic changes from the surgery, which if you're not sure what it is, could cause you to say you need to treat that as or interpret it as tumor. So we really need to do the scans early. So there is a study. It's an old study, but old doesn't mean that it's bad. And this is an interesting study where they looked at 60 high-grade glioma patients. They looked at them day 1 to 5, did a CT and an MRI on everybody. And essentially what they showed was that GAD MRI was helpful. It performed, they said, within the first 1 to 3 days. We generally like to limit it to 2 days, but even up to 3 days is helpful. And what it did is it limited surgically induced enhancement and minimized interpretation difficulties later. Not surprisingly, MRI was better than CT scan. I think we would all assume that. And of course, they evaluated surgeon impression of the resection versus the imaging. And what it showed was that the surgeons were more impressed with what they did than the imaging showed. So as I always tell my surgical colleagues, I appreciate everything that you do, but I'd like to see the data to support what you've done. This patient was also on phenytoin. You know, I always used to call these things AEDs, anti-epileptic drugs, but of course it's changed now to anti-seizure drugs because they're really not been shown to be anti-epileptic. They're really just preventing seizures. So phenytoin still go-to drug for some neurosurgeons, although most have converted. At our institution, really, unless there's some specific issue, no one's using phenytoin anymore. They're using levetiracetam, and what they said was levetiracetam was so easy to use that even the surgeons could do it. But if we look at phenytoin, you know, there's issues with generic versus brand name dosing, and you can see that with a number of medications. And if you use it, you really need to understand the Michaelis-Menten kinetics because it's nonlinear. You need to understand concerns of free versus bound. And it was used because it's been around for a long time. People are comfortable with it orally, IV formulation, those types of things. So what you would prefer is a drug that you give a dose, you measure it in the blood, you double it, you double the concentration. You want first order kinetics. But if you look at Dilantin, it has zero order kinetics. So you can increase the dose of Dilantin and you can get very small increases in the plasma concentration. And then if you're on the steep part of the curve, you could give very small doses and get a very large increase in phenytoin. So it's even hard to imagine a drug like this would be released onto the market today. But if you're going to use it, you got to be really careful in how you're increasing it. And remember, the FDA came out with a warning in 2008, and they said that anybody that uses an anti-seizure medication, and there's a lot of them, there's a small but increased risk of suicide thought or behavior. It equates to about 1 in 540 patients. And I ask every patient that I see, and we also have it embedded into our new patient evaluations, what their mood is. And I document it and I have a discussion with it. And on Epic, I do a dot phrase. So make sure you're doing that. Just to show you the issue with brand name versus generic. Again, old data, but it's very helpful. So many years ago, when the generic came out in Minnesota, they were allowed to switch from brand name to generic without notifying anybody. And this one group noticed that patients that had been stable for a period of time started having seizures. So they checked blood levels and they found out that those that were on the brand name had, for the same amount of medication, had a higher blood concentration with the brand than they did the generic. And I think that's been the same with our experiences, that generally it's about 1 tablet greater if you're giving generic medication. But if they're bouncing around and using different forms, or even, heaven forbid, which happens a lot, different types of generics, the levels can bounce around quite a bit. So you're going to have to keep an eye on things. So you have to ask patients what they're taking. My nurse would always ask them, what color are your pills, those types of things. So let's delve into seizures and brain tumors a little bit more. There's about 250,000 tumor patients diagnosed per year. 20 to 40% of them will have seizures. So should we put everybody on seizure medication or just those that have had seizures? So there is help for this. There's a position statement from the AAN. My friend Mike Glantz published this long time ago. And essentially, they came out and said, we shouldn't be using prophylaxis. I was involved in a committee that published some data just this past year, where we re-looked at the next 20 years and what came out. And we did a number of other things with it in terms of seizure use around the operative time. But we'll just sort of show you that it really comes out to the same data. So if someone's had a seizure and they have a tumor, they need to be on medication. But what about preventing a seizure, and why do we want to prevent a seizure? Well, the obvious thing is very traumatic for patients, and they could potentially be injured. And if you're a kindling theorist, you believe that seizures beget seizures, so you would like to stop the seizures to decrease the risk that they'll have seizures later in their life. What about seizure risk based on type of tumor? Seizure risk is inversely related to the grade of the tumor. When I ask the residents these questions, they always go the other direction. They always think initially the GBM would have more seizures, but in some ways it makes sense, because a person that has a low-grade oligodendroglioma and they're a seizure-agenic tumor, it's there for a long time. So they can develop an epileptic focus that can fire off seizures. And when we're doing surgery on these patients, if we don't map them for where their seizure focus is, their seizure focus may be outside of where their tumor is. So our general policy is if they've had seizures, and even if they've had surgery, we leave them on medication unless their epileptogenic focus has been removed. but you can see lower seizure risk with the higher grade tumor. And they tend to have, GBMs tend to have more symptomatic based seizures. So again, just going back to the study looking at perioperative use of anti-seizure drugs. So what around the time of surgery? Surgeons are creatures of habit, and they like to put people on seizure medication around the time of surgery. And this paper came out about a decade ago where they looked at patients that had not had seizures, and they treated them for about a week or so with either placebo or Dilantin. Phenytoin. And what happened was they actually closed the trial early because it was not going to reach its statistical endpoint. And gross number wise, those that were on phenytoin actually had more seizures, although statistically it was not different than the group that was not on medication. And of course, the people that were on the phenytoin had more side effects. So same thing, and within our position statement that we published, again, the recommendation is not for perioperative use, but I can tell you at our institutions, most of the surgeons still will put people on Keppra in the perioperative period of time. What about drug delivery to the central nervous system, and how does it affect anti-seizure drugs, chemotherapy? Well, if we give a dose of drug, oral or IV, it has to go. Typically, a lot of them, not all of them, but a lot of them will go through the liver. Some will not, which is better. But if it does, it can go through the cytochrome P450 system. And if it goes through there, you have less drug left over. Now, what kind of drugs go through the liver? Of course, our friend phenytoin goes through the liver, and most of the older generation drugs go through the liver, which means there's going to be less drug available for what you're treating. They're liver inducers. So if you take other drugs that are metabolized in the liver, it will interact with them. If they're on birth control, if they're on Coumadin, you're going to have an interaction. What about enzyme inhibitors? Well, that's Depakote. Depakote's an enzyme inhibitor, and it can actually make other drugs go higher. Grapefruit juice is also an enzyme inhibitor, so don't forget to ask your patients about grapefruit juice. And of course, not at all is levetiracetam, which would be much more ideal. Once it's in the liver, it has to get through the blood-brain barrier, so it's even a smaller quantity of drug. We'll talk about the blood-brain barrier because it's the bane of our existence for a lot of the things that we do in neuro-oncology, but we have these tight junctions in the brain, the endothelial cells, and depending on the lipid content, size, charge of the drug, it will be easier or more difficult to get into the brain. So this is a chart I put together a number of years ago, but this is essentially, it's not up to date with all the newest drugs, of course, but this is group A. And generally in the neuro-oncologic field, we like to avoid these drugs because they have significant enzyme induction risk, and we tend to like the drugs on the lower list here a little bit. I don't use much valproic acid, as mentioned. It's an enzyme inhibitor, but we tend to use the drugs on this list a little bit more because we want to decrease drug interactions. And a lot of the clinical trials that you'll go on, especially the phase 1 clinical trials, will not allow you to use an anti-seizure medication that's an enzyme inducer. So it's better to take them off early on or just never put them on those drugs. So what are the recommendations of the two groups? In patients with newly diagnosed brain tumors, anticonvulsant medications are not effective in preventing first seizures because of their lack of efficacy and potential side effects. Prophylactic use is not routinely recommended. Now, again, there are patients that you may say, I think their risk is greater. Maybe they got a hemorrhagic component. Maybe it's sitting right in the mesial temporal lobe, and you may need to decide to put them on. There are patients that I put on medication, but you still need to know what the guideline recommendation is. And generally, if they have never had a seizure, I see all the post-op patients back. I wean their medication 1 week post-operatively if they've never had a seizure. So the AN, Society for Neuro-Oncology, European Association of Neuro-Oncology, recommends no prophylaxis. We want to think of brain tumors as a chronic disease. We'd like to think of it as a chronic disease, certainly with oligodendroglioma. That can be the case. So patients may be on their seizure medication for a long time. Get them off drugs that are enzyme induced, get them off drugs that are protein bound, because we want to decrease our drug interactions. So a quick little question. A newly diagnosed GBM patient comes to see you in neurology clinic 7 days post-operatively, has never had a seizure, is on levetiracetam, 500 milligrams BID, and dexamethasone, 4 milligrams BID. You would recommend all of the following except, which one is false? Wean the dexamethasone to off if tolerated. Sounds like a good idea. Wean off the levetiracetam. Again, we just had a big discussion about that. Wean the dexamethasone to is taken twice a day. You should recommend breakfast and lunch, and we'll discuss that. Sounds like a good idea. Tell her she'll be on levetiracetam lifelong. So, of course, if you're a good test taker, you realize that question number 2 and 4 are diametrically opposed. So one of those has got to be the correct answer, and one of those is the incorrect answer. And of course, I know 100% of you would answer that the recommendation would be, in general, should wean the medication 7 to 10 days off. Dr. Punia, let me borrow this slide of his. It shows the other drugs. Look at in the last decade, how many new drugs have come on board. And again, I haven't used a lot of these drugs. We'll sort of see how they fit into our practice, but a lot of new drugs out there. Maybe some of these would be better prophylactically. Maybe some of these would be better in the surgical perioperative period of time. I'm sure there's people out there excited and interested in doing trials on these as it moves through, but always new drugs being developed out there. This is my daughter here. We were at the Olympics in Vancouver in 2010, got to hold the flame. So what about dexamethasone? Dexamethasone, I've given you the equivalents for the other steroids here, but it's the most common anti-edema drug that we use. And why do we use it? It's a very potent drug, and it has good CNS penetration, has a long half-life, has low mineralocorticoid activity, so it is a good drug. Pay attention to that half-life, at least 24 hours. It is a potent liver enzyme inducer, just like phenytoin is. So if you give phenytoin, you give decadron, you keep increasing the decadron, you wonder why their phenytoin level is staying low and you can't get it up. It's because the liver enzymes are being induced. So try not to give these competing drugs if you can. So what's the stamp? Stamps at our institution, I'm not sure if it is at your hospital, but if you go over to the hospital right now on the neurosurgical floor and you have a post-op tumor patient, the neurosurgery resident is giving dexamethasone 4 milligrams every 6 hours. Seems crazy, right? What do we say? 24-hour half-life. Why are we giving it every 6 hours? So Ingram in the 50s started noticing a reduction in edema in craniopharyngioma patients with steroids. So we've been given steroids for a long time, but we can blame the 4 milligrams Q6 on French. French was a neurosurgeon at University of Minnesota in the 60s, 70s, who decided that dexamethasone, he picked the right drug, but it would be given 16 milligrams a day, and this is how he wanted to give it. Maybe he was a military guy, and he liked the 24-hour clock or something. But again, it is a good potent drug. There is one randomized trial looking at dexamethasone dosing, and in this trial, they looked at giving 4 milligrams a day, 8 milligrams a day, 16 milligrams a day, compared those types of things. And what they showed, of course, is the higher dose, more side effects. They really didn't see significant changes in the 4 versus the 8 or the 16 dosing on these patients, other than if patients were having significant mass and herniation related issues. So, the general idea that we teach is start low, and if they're having continued symptoms, increase the dose. Or if you give them a high dose, maybe you could back down a little bit, and maybe they don't need to be on as much medication. Look at the side effects. And I've seen them all, and I've seen them all frequently. And these are mostly iatrogenic side effects. You should be ashamed of yourself if you're giving patients all these side effects. You should be on the ball, and someone needs to have their finger on the what's the dexamethasone doing. Weight gain, sleep disturbance, hypertension, hyperglycemia, increased risk of infection, avascular necrosis, so many negative side effects. You got to pay attention to. We talk to patients about all these things, and someone's always designated to be the person looking after the steroids. So what do we know about steroids? And this patient in the example I gave you had a lot of edema. And even though they had a good surgical resection, they stopped their steroids within 3 days, probably too fast. Can't stop it that fast. So dexamethasone is a steroid of choice for brain tumor patients for all the reasons that we mentioned. You need to constantly reevaluate what the steroid dosing is. And our example probably was weaned too fast. We generally recommend an H2 blocker to decrease GI side effects. The data is not great on this, but if they develop problems, then you're in a hole. So we just do it up front. We think the risk the benefit is greater than the risk. AM loading, long half-life, once a day breakfast, twice a day breakfast, lunch. We're not the military. Don't give it far apart. I always see everybody back and I say, you know, when are you taking it? They go 8 a.m., 8 p.m. I say, please move to 8 a.m. and lunchtime. The later you take it at night, the more you won't be able to sleep. You'll be peeing a lot and you'll be irritated. And they look at me like, oh, that's why I'm that way. So please improve the quality of life of your patients. Look for thrush. If you don't look for thrush, you won't find it. I say to the fellows all the time, what they see in the mouth? Oh, I didn't look, and I'll look, and there's florid thrush in there. Look, look, look. Think bone health if they're on it for a long time. They're on it for a week, not an issue. But if they're going to be on it for a long period of time, you probably should supplement them with calcium and vitamin D. And even consider PJP prophylaxis with either Bactrim or pentamidine if they're on it for extended release. So I climbed Kilimanjaro a number of years ago. I don't know if anybody's had the experience doing that, but it was wonderful. This is Brian Sau, who's the chairman of neurology out at Loma Linda. He actually just stepped down this past year. But we climbed it, I think, about a decade ago or so. So a great thing to do if you ever want to do it. Happy to talk about that as well at any point. So let's talk about the enemy. The enemy is glioblastoma. We no longer call it multiforme. When the WHO classification came out in 2016, they got rid of the term multiforme. So we just call it GBM now. And you can see on this coronal scan with contrast, this enhancing lesion in the right temporal lobe. And here's the classic board question of the pseudopalisading necrosis. You can just see it lining up here that really defines glioblastoma. And you can see a less than desirable life expectancy for these patients. This is the 2016 book, great book. But there's a new one out, so you can probably get this one at a discount if you want it, but it's a really good book. And I won't go through this in detail, but the 2016 WHO classification for tumors was a radical change in how we graded tumors. And it was a nosologic shift to classification based both on phenotype and genotype. And the important things on the 2016, if you look at astrocytoma, oligodendroglioma, mixed tumors, and been fighting for years about getting rid of this, the key was whether or not there was an IDH1 mutation. So this is the key test that needs to be done. You need to do an isocitrate dehydrogenase mutation in all your glioma patients, because you can see the path that patients take is different if they're mutated or not. In general, the take-home point is IDH1 mutation better for the patient. If they have a low-grade looking pathology, but they're IDH1 wild type and they did not have a mutation, then we need to think they have a much more aggressive tumor, and we need to be more aggressive for them. If we look at glioblastoma patients, they could be IDH1 mutated or wild type. 95% of them are IDH1 mutated or wild type. Only 5% of them are IDH1 mutated. And I'll show you some slides on this, but essentially if they're mutated, it means it arose from a lower grade tumor. So it's a secondarily generated tumor. And in the new classification, this has changed as well in the 2021. So here's the 2021 book. It's big, it's heavy, it's thicker. It's a pretty stout book. If you don't have it, get it. You should have it for the department. They're a great resource. I got lots of great information in them. Here's a slide Dr. Barnett, the head of our group, gave me a number of years ago. And this is the genetics of malignant astrocytomas. And I put up some of the changes. Here's the de novo pathway for development of GBM. And in the de novo pathway, you go right from the normal right to the grade 4. You were never a 2, you were never a 3. You went right from normal to 4. And this is what the majority of patients go through. Certainly in my age group, that's the case. And these patients often have an EGFR, epidermal growth factor receptor mutation. There are lots of EGFR mutations in lung cancer. We've tried all the lung cancer drugs, do not work to any great extent. You can also see a V3 mutation. Lots of great ideas and studies trying to target this mutation so far have not shown a benefit, so I'm not going to show you that. The other thing that I'll mention to you, and I'll show it towards the end of my talk, we'll talk about VEGF. vascular endothelial growth factor. That's also overexpressed in GBM patients. In the secondary pathway, they develop a grade 2 tumor first, and these patients have an IDH1 mutation. So when they go up the mutate again and become a grade 4 tumor, they're going to have an IDH1 mutation. So in the current classification, they did a few things. Number one is they got rid of the Roman numerals. Everything is Arabic. So now it's a written 2, not a 2, a 3, not a 3, a 4, not a 4. And all the other WHO grading uses Arabic, not Roman, so they thought they should be consistent with it. They also got rid of the term anaplastic. So we used to call a grade 3 anaplastic astrocytoma. Now we just call it WHO grade 3, got rid of the anaplastic. The only place anaplastic exists is for grade 3 meningiomas. Why they decide to leave that, I'm not quite sure. Glioblastoma now, the only time we call it a glioblastoma really has to have an IDH1 wild type. If they're a IDH1 mutant, so they come the top pathway and get there, then they're a WHO grade 4. And the concern or difficulty with this is that it may affect patients for clinical trial enrollment. If the trial says they have to be called a glioblastoma, we don't specifically call them that anymore. There's additional molecular testing that can be done to help with this. I'm not going to get into it for this talk, but it does cause some potential problems for trial and enrollment. But I think that the field will adjust to this as needs be. So gliomas are really hard to kill. If you look at this T1 GAD study over here, Dr. Vogelbaum, one of our neurosurgeons that has gone down to Moffitt to be the chair, gave me this slide a few years ago. But you can see the enhancing tumor here. And if you look at this slide here, 90+% of the tumor is within the area of enhancement. So it's a good thing to get in there surgically and remove that if you can. But if you go out 2 centimeters, to the flare signal that's out there, you can still see there's a fair amount of tumor that's in the flare. But even when you go beyond the flare signal, you can still see you have tumor. And even on the other side of the brain, you have tumor. So these are not surgically curable tumors. I always tell the patients that when the surgeon says they cut it all out, what they mean is they cut out the enhancing portion of what they could see as tumor. We know there's still tumor there. I'm going to discuss a little bit of focused ultrasound with you at the end of the talk today. And with the focused ultrasound, we're trying to give chemotherapy that will now be able to penetrate this flare lesion that's there and get into the closed area of the barrier. The barrier is open where it's enhancing. That's why the gadolinium gets in, because the barrier is open, but we want to try and get in. So what's the standard of care for GBM? Been this way for a long time. And that's the Stoop protocol. Roger Stoop is a Swiss neuro-oncologist, did this study published in the New England Journal back in 2005, where they took a large number of patients with GBM between the ages of 18 and 70 and randomized them to radiation therapy alone. And you can see on here, or radiation plus chemotherapy. Radiation given 5 days a week for 6 weeks, chemotherapy every day for 6 weeks. Then they take a 1 month time off, and we repeat the MRI scan. Radiation is done. They continue the temozolomide, now giving it at a higher dose for 5 days every 28 days for up to 6 cycles with scans every 2 months. And that's really the standard of care. In the past, we would sometimes do 12 months, and we still occasionally do that. But the data in general for the population has not really supported an added benefit to 12 versus 6 months. The counter argument has been, these are really bad tumors, so why would you stop? If you look at the Stoop protocol here, they followed patients out long-term, 2, 3, 4, 5 years with radiation alone or radiation plus temozolomide. And you can see about 10% of patients will have a 5-year survival. And if you look at the Kaplan-Meier survival curve, you can see there's a tail. And we all have this. I have patients in my practice out 5, 10, 15, 20 years with glioblastoma. We've gone back several times, re-looked at the pathology. But there is a subset of patients that will do well. But you can see clearly a survival advantage giving combined therapy. So a 60-year-old female with an unremarkable past medical history presents with progressive headaches. Imaging shows a large right frontal mass on gross resection, so is the GBM. Initial standard of care for this patient is which of the following? Radiation alone, chemo alone, combined radiation and chemo, or hospice? And of course, everybody's going to answer, because you're paying attention, combined therapy. But is this a little bit of a trick question? In some ways, it is a trick question. and I didn't supply that answer to you. And that is the NCCN guidelines, and our personal belief is that all GBM patients should be considered for a clinical trial. Newly diagnosed, is there a trial that they can go on? Recurrent, is there a trial? Because look at that life expectancy we talked of a year. We need clinical trials. Everybody should be going on clinical trials. So the real answer is really probably clinical trial. This is my grandson, Jack, a number of years ago. And my daughter would put him in a box, and she'd always call it her Jack in the Box as it went through. So astrocytoma drug resistance, it's not bad enough that the tumor infiltrates through the brain. It's not bad enough that it comes in multiple forms, but it also has drug resistance mechanisms to temozolomide. So the drug we give, it can break it down. And it uses MGMT, 6-methylguanine DNA methyltransferase. This is a DNA repair enzyme. So we're talking about how the enzyme, which is normally there for good reasons, can break down the chemotherapy. And when MGMT gene is methylated, no MGMT is produced, or we have what we call gene silencing. This is better for the patient. So hypermethylated, methylated, good, unmethylated, bad. So we measure it in all our glioma patients. You should be measuring it in all your glioma patients. So when we give the patient temozolomide on the Stoop regimen, give them temozolomide. On the 06 position of guanine here, it adds an alkyl group. If they have a lot of this MGMT present, it works by taking that alkyl group off. We're sticking it on, the defense mechanisms take it off. So as you can imagine, it could have an effect on how patients do. So within a subset of the Stoop trial, they took patients that they had good enough quality tissue on, and they looked at who had methylation and who was unmethylated. And there was a clear survival benefit for those that were methylated. That's good. Almost 2 years versus 15 months. And you can see that very clearly. If you're methylated, hypermethylated, good, unmethylated, bad. Check it on everybody. It's kind of almost a 50-50 with the patients. So what happens if a patient comes and sees you that's unmethylated? Do we still give them the Stoop protocol? If there is not a clinical trial, we typically do. There's still benefit, just not as much. This is the Checkmate trial. Oops, sorry. This is the Checkmate study, 498 that we were involved with, a randomized phase 3 open label study where they gave nivolumab, one of the novel immune checkpoint drugs, in place of or as a alternative to temozolomide in unmethylated patients to see if they will do better. This is the randomization. So newly diagnosed, unmethylated, got radiation nivolumab followed by nivolumab, or radiation temozolomide followed by temozolomide on the standard. And again, the checkpoint inhibitors, simple way of thinking about it is that it uncloaks the tumor so the immune system can find it and the T cells can kill the tumor cells is the easiest way to think about it. So the study itself, unfortunately, did not meet its primary endpoint, was a negative study. So unfortunately, it's back to the drawing board, but at least in the way this trial came, there was not a clear benefit of substituting the checkpoint immunotherapy drugs for temozolomide. Here's a novel approach, though. This is Tim Klufsky out in California, and they gave Neo-Adjuvant anti-PD-1 immunotherapy. So they said, let's give the drugs before surgery when there's a lot of tumor that's there versus they have tumor, they don't have a lot of antigens, maybe there's some effect there. So they gave the drug, took them to surgery, then gave them the drug. And what they found was that single dose pembrolizumab, if you look at the overall survival when it's given before, you can see they have a significant improvement in their survival. So maybe there is something about if there's a big enough antigen load that the system gets primed and there can be benefit. So we don't want to abandon things that might be helpful without fully looking at them. What other treatments are approved? There's tumor treating fields. You can see we have to shave the head. We put these pads on and we give a low dose electric current. There's a big battery associated with it. And it's thought to be an antimitotic therapy. It was approved in 2015. And I won't go through the studies with it, but essentially Stoop did a study where they gave temozolomide and tumor treating fields versus temozolomide alone after the standard radiation and chemo. So they just added this after the end, and they increased the overall survival up to 20 months. So clearly a survival benefit. So should this be the new standard of care? You know, patients don't want to shave their head. They don't want to wear these things. They got to wear them for a long period of time. But if patient can't get chemotherapy, certainly a good treatment to give them. And a study was done where they just gave, after radiation, they gave temozolomide versus the tumor treating fields, showed to be efficacious treatments together. So certainly something that your patients could utilize. So comparable to cytotoxic chemotherapies with fewer side effects, and when used in conjunction can decrease or can increase life expectancy. This is a trip I took to the Douro Valley in Portugal several years ago. I went on a riverboat. You just go down, you stop at the Sandman, get some port for the day, stagger back to the boat, go down to the next winery. Again, highly recommended. What about oligodendroglioma quickly? Oligodendroglioma, a much better tumor. This is the board question, the classic fried egg appearance of oligodendroglioma. Molecular genetics, very different, going from the oligo to the grade 2 to the grade 3. And the key here is this LOH, loss of heterozygosity of the chromosome 1, the short arm, or the P arm. P is just French for petite. And it's a translocation with 19q. And that's what really defines an oligodendroglioma. And you can see that we look at this thing called 1p19q, just a translocation of these. And for the new WHO classification, you also need to have an IDH1 mutation. So we don't really look so much under the microscope now and say an oligo. To call it an oligo, they have to have a 1p19q co-deletion, and they need to have an IDH1 mutation. You can measure it by FISH or PCR. You can mark the telomere and centromere and just count the dots. There's advantages and disadvantages of both. Again, another old study, but a good study looking at grade 3. You can see here they called it anaplastic, but we would call it grade 3 now, oligodendrogliomas. And it was a study that looked at PCV chemotherapy. So they looked at radiation and chemo versus radiation alone, just like the Stoop, but long before. And you can see on the old slide that Karen Cross, who did this study, who I did my training with, you know, it was back done in the day in Canada where we just did CT scans, but gave intensive PCV chemotherapy. And essentially, if you look at the survival curves, those have 1p19q co-deletion. So the real high-grade oligodendroglioma patients, look at this, average survival with combined therapy, 15 years. So 15 months with GBM, 15 years with anaplastic or grade 3 oligodendrogliomas. If you do radiation alone, look at that, half the survival. So we got to treat these folks with combined therapy. And if we just followed these patients for 5 years, we would have thought there's no difference. So we got to follow patients out long-term and make sure we're making it. And this number isn't set in stone. As we continue to follow, this goes to 15 years, 16, 17, 18. We're not sure what the endpoint is with these patients. So the conclusion is 1p19q co-deleted tumors live longer after radiation and PCV, but most of us will replace that. And there are some ongoing trials that suggest that that's okay to do, but there are still some centers that will choose to give PCV. If most want to give the PCV, they'll usually give the procarbazine and the CCNU and forget the vincristine. A lot of question is, does it get through the blood-brain barrier? And it causes a lot of peripheral neuropathies. If you want to keep your neuromuscular folks in good shape, you can do that. We published this a long time ago, or we looked at almost 100 oligodendrogliomas in ours, showed the same thing, the prognostic benefit of the 1p19q, and we've almost turned it into a chronic disease. So let's just move forward. This is when I was in Tanzania climbing the mountain. This is a picture of the Ngorongoro crater. You can see the lioness here. You can see the zebras and the wildebeest. There's no place to hide here. If you're squeamish or you don't like it, look away. But here's the lion moving around. And of course, it's the females that do all the work, and then the male will come and eat it. But it looked like the zebra lost that day. So Judah Folkman, father of anti-angiogenesis, born in Cleveland, wrote a great paper called The Angiogenic Process back in '71, where he really elucidated the rule of the artery, which is supreme. And you can see with normal vasculature, there's lots of things going on here that we can target in GBM to try and affect blood vessels to decrease vasculature to the tumor. And we've blocked all of these things and unfortunately haven't shown a benefit, but we'll concentrate on the VEGF, the vascular endothelial growth factor. And you can see how ratty blood vessels look here. and they're leaky. And we have a drug. So if somebody has VEGF, it's used, it's known a lot in other cancers. And if you have vascular endothelial growth factor present, it causes more survival, proliferation, and migration of tumor. So it seems like a good thing to block it. We have this drug called Bevacimum, which we can block, and it just does all the things that I mentioned. This is the first study that looked at using Bevacimum in GBM patients, because it was used in systemic patients, and the thought was, hey, GBM patients overexpress VEGF, let's use the drug. So she gave it to these 21 patients, and look at the response rate, 43%. Normal response rate is 15%, and you saw a complete response and stable disease. So everybody was so excited. And then we realized it was a little bit of smoke and mirrors. This is in a radiation necrosis paper, but you can see here the pre-treatment and post-treatment with Avastin, and look at the enhancement here in these patients. You see clearly less enhancement after the Avastin, and look at the brain edema, significant improvement in brain edema. So what we're seeing is that the Avastin is affecting the blood-brain barrier, and it's taken that widened barrier and closing it up, and now the gadolinium doesn't get in, and that's why we're not seeing it, and affects the interstitial fluid pressure, so it takes the water out and the edema comes down. So really good for treating edema, not so good for treating tumor itself, but it can also do nasty things. You'll see this on the neurology service. So, it can affect wound healing, bleeding in the brain, hypertensive crisis press, nephrotic syndrome, arterial thrombotic events. So it can cause all these types of things. I've seen them all. You'll see them. So what about adding Avastin to the upfront setting, to the Stoop regimen? If radiation and therapy and chemotherapy are helpful, let's add Avastin as well. 2 large clinical trials that were done, one in Europe, one in Canada, done at North America, done at the same time, both negative trials. So adding, unfortunately, brain tumor is the king of non-significant trials, which is, I showed you the von Hippolindao stuff up front. So it is used in the recurrent setting. We don't use it in the upfront setting, unfortunately, unless people have significant edema and it's really affecting their quality of life. The grandkids still play in the back, ice the pond in the back. So let's move to the last couple of topics in the last 10 minutes. We'll talk about interstitial thermal therapy, or LIT. We did the first in-man treatments of it here a number of years ago, Dr. Barnett. You can see the catheter probe here, and it uses heat, thermal heat, and we need to get hot, 57 degrees, to cause coagulation and death of tumor. It's done real time in an MRI, and we can get real-time imaging thermography, which is great because you can plan and see the area that you're treating. Here's an example. Pre and post, 24 hours between these, axial coronal sagittal image. You can see where the patient was treated here. You can see the immediate post-treatment. The next day, you can see the enhancement already a little bit decreased, but you can see that there's some enhancement just outside of the area. So if you look at the same patient 1 day, 13 days, and 56 days later, you can see those areas got better over time. So it's done in our intraop MRI. A small burr hole is made and the probe is put in, and the surgeon is outside of the room for the treatment. We only show our worst cases, of course. Good for treating deep-seated tumors. You're not going to be too excited about doing a resective surgery on this. You can see 24 hours later, kind of looks like an eggshell appearance afterwards. Here we are 3 months later, 1 month later. This patient 2 years later with newly diagnosed GBM. We are still treating with Stoop regimen afterwards. We may still treat him with a clinical trial afterwards, but you can see the nice response this patient got. Here's a patient with a cingulate GBM, again, bad location to do things with surgically. 24 hours later, you can see 3 months later, 7 months later, a year later, 14 months later with this patient, newly diagnosed. Look at this thalamic GBM. You're not going in there and removing this thalamic GBM on this patient. You can see here as we followed this patient over time, I didn't put the time points down, but this year later, they would have done standard therapy, but look at the improvement in this paper, in this patient. So laser interstitial thermal therapy, I'll just mention, we use a lot. We also use it for treating radiation necrosis, and we have a number of clinical trials ongoing where we're doing expedited treatment. So let's say this patient came in to see us We also have clinical trial now where we have a high suspicion that it's a GBM. We will give them, we'll do a frozen, and if it shows glioma, then we'll treat them, and we do expedited radiation and chemo. So within a week, we start giving their radiation and chemo to see if there's going to be a benefit in treating faster with these patients. This is a trip I took to Halong Bay several years ago. It's a beautiful thing. This is a big cave that I'm in back here, but stayed in a junk out here overnight. And again, well worth, probably not a good place to visit right now, but well worth visiting. So the final topic is ultrasound. Ultrasound's been around for a long time. There's been a lot of interest in using ultrasound as a treatment for tumors or functional treatment within the brain. But it suffered the fact that patients couldn't get the ultrasound beam through the skull. Patients would have to have a craniotomy, so a lot of people lost interest in it. But MRI came along, intra-op MRI came along, and this really opened the whole field up where, just like with the laser interstitial thermal therapy, we can use intra-op MRI to help guide the laser of what we call focused ultrasound. And there was development of transducers and sonications and in the field, so this became much more interesting. This is the transducer that people use over here. And you can see that this is a patient here in the MRI scan. You can see they have a head frame on here. They have a water bath around because when they're using as a thermal treatment, it causes a lot of heat. So they have to give a cooling to cool it down, and they have a transducer that's around to give the tumor or to give the treatment. So it's been used functionally to treat the thalamus, subthalamus, or basal ganglion pain and Parkinson's disease and essential tremor, and is approved as a therapy for essential tremor in 2016. And we are doing these, and I'll just show you that. But we're also opening up avenues of interest for treatment of GBM. And if you look at it, here's a patient that is treated at our institution by Dr. Nagel for the thalamus. You can see the thalamic treatment here. And it's kind of cool because the patients are laying back and they can treat them in real time. They can cook them not at 56, but they can cook them in the mid 40s. So they can give a little bit of a treatment and then they can monitor their tremor. You can see the spiral, the Archimedes spiral here, their handwriting, and you can see after the treatment it's better. But they can have really bad, look at that, you can't even read their handwriting here. And you could treat them and you could go, okay, I know I'm where I'm at. They use an atlas to determine it really currently, and look at how much better this patient is doing. And if you look at the data for this, the tremor significantly improved. All the blue is improved tremor. So a very good treatment for thermal therapy for tremor. But what about for treating tumor? So we do have some interest in treating with the HIFU, the high intensity focused ultrasound. But we recently finished a trial with LIFU, low intensity focused ultrasound. And here we're not trying to give high temperature and kill tumor. We're trying to give low temperature and open the blood-brain barrier. And again, we're using our friend, the MRI, and we're using a transducer that was developed that allows us to treat all around the brain. And we give much less energy, 1% of the energy that's required for treating the high intensity. We're not creating all that heat. And the secret sauce with us is that we inject microbubbles and we use DEFINITY. And the DEFINITY, I'll show you a picture, temporarily opens the blood-brain barrier so we can now get the chemotherapy in. And in the trial that we did, the max volume that we could treat was 110 cc's, but it was dose escalation. I'm going to show you a patient, but I can't show you all the data. The company's going to the FDA right now, so we can't share any of that. But once the barrier is open, it stays open for about 8 hours, and then we can give drug. But there's a lot of implications. There's a lot of interest currently with Alzheimer's disease. If there's any Alzheimer's folks out there where they're doing the same process without the DEFINITY, without the chemotherapy, and opening the blood-brain barrier and trying to get all the proteins out of the brain and seeing if there's a benefit. But this DEFINITY is a microbubble that's injected, and it goes around the circulation. It results in transient loosening of the blood-brain barrier, and it opens the gaps. And here it is in cartoon, a little bit hard to see, but we give the ultrasound over here to an area of the brain. We have these bubbles in there that will open and expand, and it does several different things to the junctions and the proteins, the vesicles there. But in general, it just opens the gap, and now drugs can get in. So the Focused Ultrasound Foundation is a nice website to go to. They did a big workshop in 2015 and 2021, and you can look at the reference for that. If you want to look at trials going on in your area, you can look at clinicaltrials.gov, and I'll just mention a LOFU one. Here's the frame that we put on. I do this myself. This is the frame. And you can see here's a patient with the frame on. You can see their craniotomy over here. You can see we place the frame really low. We give them low 1 or 2 milligrams of Versed. We inject some lidocaine around here, and we give it just above the brow. And we can see you can shave the head. We give them a haircut, shave the head. On the newer, as the trial went through, we could stop shaving the head. They had to have a good haircut. This is the bladder that's used. We use it for both the HIFU and the LOFU, and although it's not as much of an issue for us. Here's the transducer that we use. It's different than the one that they use for the HIFU, but again, we do it in an MRI. We have real-time monitoring, so we see what's going on. You need to be best friends with your neuroradiologist. This is the cooling area over here. This is the DEFINITY here. This is one of our patients in here being treated. Here's Dr. Lockwood. Here's the treatment. You can see a real-time treatment, same thing. We can see the real-time opening of the barrier. You can see the beams that went in. The red are the blocked ones. And you can see here's a patient's tumor. Look at the size of that, right? That's a big volume in this patient that we're treating. And here's a sonication. It's a 90-second epoch, and you can see that we're treating it. So we'll treat this for 90 seconds, and then we'll draw a target up here. We'll treat it. We'll draw a target here. We'll treat it. We'll draw a target. They're here for a few hours while we're treating it. Here's the last patient that we treated on the trial. Again, it was a phase 1 trial. And what the trial does is they come in monthly, we sonicate them and give them IV carbo. So ideally, we would treat them 6 times, give them IV carbo 6 times, and we increase the dosing. And when this patient came on trial, we're able to treat the entire 110 cc volume. So look at this tumor the patient had, big tumor, lots of edema, mass effect. After the first treatment, looking better, second, third, fourth. You can see as we came down, this was April. Patient was just recently back, and there's almost no enhancement. Never been on steroids, significantly improved, excellent quality of life. Recurrent GBM patient, doing great. So what have we learned? We've learned that we want to do a post-op MRI 24 to 48 hours after surgery. We don't want to give anti-seizure drug willy-nilly, just as we should. Steroids need to be AM loaded. We need to think about what we're doing. We need to consider trials for our GBM patients, standard of care, radiation and chemo, maybe TTF. 1p19q is a marker, a prognostic marker, and it defines oligodendrogliomas. IDH1 should be doing on everybody, prognostic marker. MGMT, treatment marker. Bev is good for treating brain edema, but not so good for treating tumor. LIT puts another tool in the belt. Focused ultrasound, a lot of potential excitement, and we need to think trials. I know, Matt, as oncologists, we always feel this way at times. We feel we're all alone out there. This is the oval. My grandson is skating on out here, but we're not all alone, and we're all here to support each other. And one of the nice things about the neuro-oncology community is it's a small group, and most of us know each other. So we're all here to help each other. So that's it. I know it's a lot of stuff, but I'm happy to take any questions. And should I stop sharing my screen?
Yes.
Okay, so let me do that.
Yeah, thank you, Dr. Stevens. That was a fantastic overview. And so
is that good? Is that good, Corey? Can you see me?
Yes, you look great.
All right. So, Matt, happy to take any questions, or if everybody's exhausted this early in the morning there, that's okay too.
Yeah, so we're open for questions. And I guess one question I have, have you done much epilepsy surgery for the low-grade glioma patients, long-term survivors? Does Cleveland Clinic integrate that not infrequently in the care of those patients?
Yeah, I like your question. And we actually looked at this a number of years ago. I had a nurse practitioner for 20 some odd years who retired a few years ago. And she had looked at this and I think presented it at the AAN a number of years ago, because we had these long-term oligodendroglioma patients that were doing well, but were on 3 seizure medications. And, every time they'd come see us, their tumor's stable, but they're either still seizing or they're just on so many medications. So we started talking to our epilepsy colleagues and said, hey, these patients have been stable for quite a few years. Let's look at maybe mapping these people. So we actually got a handful of patients and started mapping them, took them to the epilepsy unit and started mapping them and did surgery on them, and actually showed we're able to get most of them off their seizure medication. So I like your question, and I think it's a good idea. And if you really want to ingrain your epilepsy folks and get them involved and get them excited, I think it's a good thing to do. Stable, long-term, low-grade patients that are on a lot of medication, well worth doing. And in our experience, worked out very well. You know, if you can't find the seizures, or if they're coming from too many places or that type of thing, that's fine too. And very often we wouldn't necessarily just be removing the tumor. We really targeted the epileptogenic focus and had very good success with it.
Excellent. And we have a question from one of our epileptologists, Dr. Doherty. He says, thank you for the talk. One of the consistent referrals we get in epilepsy and post-op brain tumor is a wean off anti-epileptic medication with new or repeated seizure. One way to potentially make that risk lower is to check an EEG prior to weaning off medications. If the EEG is evil, weaning should be reconsidered.
Yeah. Yeah. So again, ultimately, you know, we have to make our clinical judgment on these patients. If they've never had a seizure, our standard is not to do any EEG monitoring on them. But again, if you're concerned that maybe there was something goofy going on, but I can tell you with these infiltrating tumors in general, if we're not quite sure, you may or may not have had a seizure, we almost always err on the side of keeping them on medication. We will do 24-hour EEGs. We can do ambulatory EEGs on our patients. We can do them for a day, a couple of days as it goes through. But in general, for me, if they have had seizures, and even if they've had surgery, unless someone is removing the epileptogenic focus, we leave them on medication.
Mm-hmm. Fantastic. Any other questions?
Glenn, great talk. Thanks again. I feel like I'm ready for the boys.
Well, I wanted to try and make it practical.
Yeah. So for steroids, I know you led a trial with Boswellia, post radiation and surgery. Do you use any alternatives to Dex?
Yeah, so it's
Metformin, Celebrex, you know.
Yeah, so thanks for the question about. So we did a Boswellia trial was a good news, bad news, and you know, careful what you wish for. Is through the NCI, and you know, we did it as a diet and a Boswellia trial, and the theory there is to affect 5-lipoxygenase, 5-LO, and 5-lipoxygenase affects the arachidonic acid, as you know, cascade to try and decrease it. And I got to tell you that I could tell you stories on end about working with the NCI on all the issues that we had with it. But the end result of it is that sometimes that's why maybe vegan diet may be helpful for patients. But we do have some patients take Boswellia. The problem is on the trial, you know, we used a extract from Germany that was very purified, and you don't know what you're getting when you get it otherwise. But the answer is yes. We do have some patients that we'll put on Boswellia. Our radiation oncologist, Dr. Chow, who runs our radiation necrosis program, has just started recently using the COX-2 inhibitors. You mentioned the Celebrex. You know, there was Eric Topol was here several years ago. I actually just read something about him about the COVID stuff. He's a cardiologist here. And, you know, we were going to do a big Celebrex trial here with meningiomas because they're COX-2 inhibitors many years ago. And when he was at the clinic, published something just about a month before we were going to come out looking at cardiac risk and coronary risk with patients that are on COX-2 inhibitors. So it kind of stopped that trial immediately. But our rad-onc has started using the COX-2 inhibitors a little bit as well. You know, we'll also use Trentol, vitamin E. We use those more for radiation necrosis per se, not so much with it. But, you know, we've had great success with LIT to decrease radiation necrosis. Avastin works so well, but you know how it is. There's some patients you just can't give it to. Right. So we're like you. We do with all of these types of things. But, you know, if they want to take a vegan-based diet, may have some benefits. Certainly the Boswellia may have some benefits as well.
Okay, cool.
But if they're on a lot of steroids, you're not going to get them off a lot of steroids.
That's true. That's correct. And lit, you're using routinely in the upfront setting for those patients with the deep-seated tumors,
Yeah, so the deep
rather than just a biopsy. You'll
Yeah,
just
so the
do a biopsy
deep-seated-
then lit.
Yeah, so the deep-seated tumors, they'll consent them beforehand if it's in the thalamus. And the benefit of it is you can do a biopsy. So we'll at least have a frozen and we at least have an idea of where it is. You know, it doesn't mean that it turns out to be, you know, some patients it turns out to be something different. But, you know, we don't want to go back and do a second surgery on those folks. So occasionally some patients may decide not to and they elect to bypass it. But yes, we are, you know, if everything fits the size and those types of things, then we're doing it.
Right. Okay. Thanks.
Well, fantastic. It looks like we're several minutes past the hour here. So yeah, if you guys have any other questions, feel free to email me and I can get in touch with Dr. Stevens. Yeah, thank you again, Dr. Stevens, and everyone who's joined us today. And we, wish you a good morning and rest of the day.
Well, I'd like to thank you and Kester as well, and Corey, of course, for helping me. I didn't screw up too bad, I think, with the with
You
it. So
did
Corey
great.
must have done
great.
something great. So you better keep her on board over there. You might have to have her come visit us at the clinic. No.
Yeah.
All right. Well, listen, thanks everybody. And as I say, Matt, if you want, I can certainly send Corey the slides if
Yeah, those will be great. There's
if
some.
you have any questions, I'm happy to answer those if they come in. And we'll be in touch.
I'd definitely
anyway.
be interested in seeing those slides.
Okay.
Thank you.
All right. Sounds good. Nice seeing you guys.
Thank
All right.
you.
Bye-bye.
All right. Take care. Bye-bye.